Right. Assalamualaikum and very good afternoon, everyone. Thank you for joining our webinar today. For your information, we are quite honored to have a very good-looking, I haven't finished Dr. Masri, a very good-looking moderator and speaker. Gitu. Right. I think people are waiting for your lectures actually. Just a quick reminder, kindly mute yourself upon joining our webinar. And then if you have any question to Dr. Masri, you can actually post in the chat section. I will read it. I will read the question for you. And then at the end of the webinar, and then right before we end our webinar, Dr. Rohaida will post a link for the attendance for your CPD points. Before we start, let me introduce Dr. Masri. I'm sure you all know Dr. Masri, but I think I say it's an honor to have him here. Dr. Masri Muhamed graduated from National University of Ireland, Galway in 2005. And then he completed his internship and worked as a senior house officer in pediatrics and neonatology in tertiary hospital in Galway and Cork, Ireland for 2 years before being promoted to registrar in pediatrics and neonatology. He had worked as a registrar in several tertiary hospitals in Galway and Dublin. During his time in Dublin, he was a member of National Neonatal Transport Team of Ireland. He then later obtained diploma in child health by the Royal College of Surgeons of Ireland in 2010, and later subsequently obtained membership of Royal College of Physicians of Ireland in the medicine of childhood in the same year. He then returned to Malaysia in 2013 after 7 years of working in pediatrics, 4 of which dedicated purely on neonatology. Upon returning to Malaysia, he joined University Technology Mara as a senior lecturer in pediatricians. He completed his neonatology subspecialty training in 2015 and was included in the NSR as a neonatologist in 2016. He is an active member of several medicine, pediatric, and neonatology associations. He's a very passionate educator, including to the public, and has been invited as a speaker in numerous events and television shows. He is a strong advocate for public health, especially in terms of promoting vaccination among children. I think without further ado, I'll pass the session to you, Dr. Masri.
Jazakallah khair, brother Faisal, Dr. Faisal, the most handsome guy. I knew that he was actually referring to himself in comparison with myself and himself. I would say that he's a better looking guy. Anyway, thank you so much. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and salam sejahtera to all that actually willing to spend your lunch hour with me and together with the Malaysian Association of Pediatric Dentistry today. I would like to say my sincere gratitude, honors, and great pleasure to actually to accept this talk. Initially was Prof. Anna Puri actually that invited me, and she said that wanted something is quite different, and I said I choose a topic. Then complication of prematurity is the choice topic for today. Okay, and after thanking her, then I also would like to thank the society or the association itself for giving me the chance to talk about the complication of prematurity. Also, thank you to the president, Dr. Joanna, and also a small thank you as well. Not that small; it's quite big. To Dr. Kalisha, is she a doctor yet? I think she is. Dr. Kalisha is the creator that designed all those small videos. Thank you so much, Kaka. I really appreciate it. Okay, so straight to the point. I don't really want to waste your time with all this small talk. I'm actually going to share the slides that I'm actually going to show to you. So here we go. All right. I hope everyone can see this, okay? So today, I'm actually going to talk about the complications of prematurity. This somewhat is going to be like not in the extent in terms of the whole prematurity or neonatology. So the contents today, I'm going to talk about the what its risk factor, the complications. I'm going to go to run a couple of complications. Probably some of the terms is actually quite new for you, but certainly I will give the abbreviation being unabbreviated if it such works. Home preparations. Now the a lot of parents will have a lot of problem difficulty, you know, in terms of preparations, getting ready to go back home. They feel a bit scared, they need a bit of support in them. Okay, and then you got the follow-up. What kind of follow-up do you actually do? Okay, growth and feeding, the development, association with any form of psychiatric or psychological issues. Okay, and we got the, of course we want to include the COVID-19 issues, whether that the children are allowed to get the COVID-19 vaccine. I mean, I'm pretty sure that most of the viewers today actually received their first dose of vaccine. I'm actually due to have my second vaccine next Tuesday, and I hope everything gonna goes well. Okay. The last when I finish my talk, I'm going to do a bit of demonstration, real life demonstration. Of course, there's no baby, but there's certainly a mannequin. All right. Okay. Prematurity. Now, to be honest though, prematurity is something that we actually scared of as a parents because that the baby is actually not ready. It depends whether the baby actually can be delivered at 24 weeks, as early as 24 weeks. Believe it or not, it actually can be down to 23 weeks. My personal record is 450 grams. Okay, 450 grams is very small. The baby survive. Okay, but there is complications. Put it this way then, the smaller the babies, like the lower gestation, we're talking about 24, 25, less than 28 weeks, the higher complications or any form of damaging factors can actually happen to towards the baby. Okay, so why prematurity even exists? Now, if you ever come across, now this is my own personal experience, if you got a baby less than 24 weeks, their eyelids are fused. It's actually like fused completely. Okay, now, when they grow a lot more older, though, this middle part then it will become tetas. It's just like disconnected tetas. Lah kata Melayu dia akan tetas sikit, and then finally they open their eyes. That's how beautiful the God's creation is. Yeah, okay. The prematurity become a lot more high occurrence because the technology, okay, and the subspecialty that we have, the manpower, the people actually looking after the babies is actually getting better. Okay, so who at risk actually having a premature baby that deliver premature baby? First of all, then multiple pregnancy. When you got multiple pregnancies, that's two crime. It could be twins, it could be triplets, and even like 5, 6. I don't know what's your personal record of saying that. My personal record is actually triplets. Then yes, I heard about all these quadruplets and so on. So the higher the babies inside the womb, then the higher risk of getting prematurity because there's no room. Okay, right. Okay. Now, if there is history of prematurity, usually we have record that if a mother deliver a premature baby before, the tendency to get another premature baby usually is quite high. We see that quite often. So we say that, oh, mak ni lagi ke, mak tu ke, or ini adik kepada si Pulan, that kind of way, yeah. Okay, now how about the structure or the anatomy of the mothers, like, or the gynecological parts then? I mean, the uterus itself, the cervix, and or it could be any form of infection, which is number one, really. If there is any form of infection like urinary tract infection, in other words, like kencing kotor lah, in Malay word, yeah, or any form like GBS, group B streptococcal infection, then this baby is not comfortable inside. So they have to be delivered. Doesn't matter whether it's normal delivery. Now, as a matter of fact, though, if you got infection, then it will actually trigger premature labor. Now, if the baby actually not well or the heartbeats become low, usually the obstetrician will actually just do cesarean section. Okay. Now, if there is component substance abuse, gestational diabetes mellitus, to be honest, yeah, GDM or gestational diabetes mellitus is got the opposite. Usually the baby is so big, the big and chubby. The record I seen is 5 kilogram normal delivery. You can go up to 5 to 6 kilogram normal delivery. Can you imagine that? Okay, usually they go the opposite. Now, if the mother has any form of comorbidities, got diabetes, heart problem, hypertension, so on. Okay, now, of course, that we know that any form of IVF, a lot of parents out there are willing to put a lot of money, to invest money to have this precious baby. Okay, everyone keeps saying that, okay, she has, or the parents only have one baby. To me, no, all babies precious. Doesn't matter you're number one or the only one, anak tunggal ke, anak 6 ke, anak 8 ke, all baby are precious. Okay, but for them though, the only baby that they have conceived by IVF is precious. They spend a lot of money, they go through a lot of procedures, so they really look after this particular baby. But unfortunately though, the IVF babies tends to actually been delivered early, hence prematurity. Okay, so what are the complications? Okay. The complications that we know that are listed at the front that you see here is that you got respiratory distress syndrome, the poor feeding, the heart failure, and yep. Uh, I'm going to mute all of okay, right. So you got the poor feeding, the PDA, the heart failure, intraventricular hemorrhage, PVL, the bacterial cause any form of infection. You have to remember that not only from the beginning that the baby has a problem infection, when they come out, they go to a neonatal intensive care. They are a lot more prone to get infection. Indwelling catheters, and they got a lot of other things. Yeah. Okay. So the long term, then they got could be a chronic lung disease requiring oxygen to go home. They got problem with their eyes. They got problem with feeding, and the one that we wanted to avoid the most is damage to the brain. You have to remember though, these kind of babies are prone to get hypoxia. In other words, then they are depleted in oxygen. There are certain times or before delivery or after delivery, whenever though, if they have compromise in oxygen supply towards the brain though, it will damage the brain. Our brains need two main things: oxygen, glucose. If any of these is depleted or lack in, the damage is severe towards the baby. It's going to lead to cerebral palsy. Okay. Now, in terms of dental, though, dental, I would just say like, I don't really know, but you can read it through though. I'm not going to touch it and I won't embarrass myself, to be honest. Okay. Right. Respiratory distress syndrome. Now, you can see here then, usually that the babies are delivered premature. The main component, the main organ that is premature is the lung. The lung are not ready. Lung is coated by this chemical, you can say, is called surfactant. Surfactant, can you imagine now? Can you imagine, yeah? Surfactant is trying to reduce the surface tension. So can you imagine yourself actually blowing a balloon? Everyone gone through that, okay? When you initiate blowing the balloon, though, there's huge amount of resistance, okay? And then when you go along, then it becomes bigger, it becomes easier and easier and easier. But if you go beyond the pressure, it will pop. But to initiate the pressure is quite difficult. Now, imagine that in the alveoli or inside the lung, the surfactant reduces the surface tension then, okay? Normally or naturally that the baby's body or our body will create our own endogenous surfactant. We create our own by the type 2 pneumocytes. But if it's lack in that, we can instill it, put it down the trachea using the laryngoscope and instill it inside the lung. Technically, kau lemaskan budak tu, tapi using the surfactant, it will help. It will definitely help. Okay, so RDS steadily then is the main thing that can also kill the baby and carries a lot of complications such as pneumothorax, hypoxia, chronic lung disease, and so on. Now, this is called the ground glass appearance, okay? I don't need to dwell on that, but you can see this, the location of the endotracheal tube. This is one of the indwelling catheters, and you got the umbilical arterial catheter heading towards the heart, and also there's umbilical venous catheter heading towards, it shouldn't be there, but it's inside the liver. Okay, this is just a picture that I took from somewhere. Okay, this umbilical arterial catheter, we literally put a lot of things inside the small babies. Can you imagine? Okay, so who are at risk, or which baby are actually at risk of RDS? The premature baby, okay, the mother has gestation diabetes mellitus, they got asphyxia or any form of infection will expose the baby themselves into respiratory distress syndrome. Now, what are the clinical signs? Usually they come out, then they grunt. Okay, they grunt. Do you know what's grunt called? You know, like macam yang orang main tennis tu, that is a grunting. But the baby grunt like this. I can't believe I'm doing this, but yes, that's how a baby grunting. Now, when the baby grunt though, that means they are, please help me, I need your help. Okay, they are doing their own CPAP, but eventually I'm going to be tired, I am going to collapse. So help me, please. Okay. So the signs going to have desaturation, they look like they're labored breathing and they struggle for breathing. And then you got, when you do blood gas, they got acidosis, respiratory component. This is a picture that I took when I was working in a Rotunda maternity hospital, the oldest maternity hospital in Europe, in Dublin. Okay, so you can see that that's how typical. This baby is 32 weeks gestation. This is one of my sister. Okay, although he is a male, is one of the best sister that I ever come across. He's very capable. He's skillful and everything. Yeah, so you can see that that is a CPAP machine that located in front of the baby's nose, pressing. It has to be tight, so they got a strap behind there. So somewhat it pressurized this around the mouth and the below around the chin area, but also there are design of a nasal prong as well that presses middle of the columella. Now, sometimes though, if you don't particularly look after this particular area, you press the columella, then it can create columella necrosis. Can you imagine all the max fact people have to like repair this together with plastic surgeon? They have to repair this. If not, it will damaging. It's permanent. Okay, so you press it very hard because create the pressure. The baby will not able to tell. Okay, they don't talk, so you just have to monitor them. Okay, they got the rice tube for feeding and got the brenula. Okay, this baby is lying in prone position to help and to aid their breathing. Okay, now how do you manage it? Like I mentioned to you, we can instill RDS, we have to give the oxygen, we're going to make sure there's no form of infection, and then the baby should be okay. But the problem, despite saying okay though, there's a high risk of the baby going to have chronic lung disease. What does that mean? That means that despite all the oxygen that be given in the whole world, nak habis satu hospital punya container, okay, they still want the oxygen. It's like a typical smoker that refuse to let go the cigarettes. So how do we define this kind of child? It's called chronic lung disease or bronchopulmonary dysplasia. They're just not willing to let go the oxygen. The lung is actually scarred and damaged then, and sometimes we even let them go home with the oxygen tank. Can you imagine that the cylinder of they just brought it home, and they have high risk of apnea, they have high risk of problem of feeding, and so on. It's scary, believe me. And I'm sure inside this chat room, in the participants today, there are mothers out there have premature babies, or even the father as a parent has premature babies, and it's a tough, long journey. But I tell you, it's not easy at all. Okay, now this is what surfactant can do. You can see on the left side that is called hazy, ground glass appearance. And then after the surfactant, you can see it's well aerated, where you can see that, the black area is aerated, and all this white thing is just like, it's just very stiff lung, or the respiratory distress syndrome, or ground glass appearance. Now, again, this is another baby. Why in particular I would like to share this particular picture though? You can see this is a close-up picture that I took not using my iPhone, certainly, but using a special, just my camera that I have. Okay, this baby got bilateral pleural effusion, where we need to put two chest drain, bilateral chest drain. One here, you can see there's a scar there, and the other side is on the other side. Now, this is the position of the endotracheal tube. Okay, later, I'm going to show how we insert the endotracheal tube. This is a typical endotracheal tube. It's quite soft. It's very soft. Okay, got all the landmarks and got the vocal cord marks over there. Okay, I'll show it to you later on. So technically, it's the same thing. Okay, and being connected towards the ventilator. And again, this baby actually, you can see at the perioral area, it's all crowded. Can you imagine that? One thing about being a mother or a father, though, they love to see their mouths of their babies. Even like sucking reflex kan. Macam yelah kita nampak anak-anak kita kan, bila nak menyusu badan tu dia, ataupun menyusu botol kan, dia nampak mulut tu komat kami. It's actually a beautiful thing to see. That's why, alternatively, me personally, I don't put the tube in the mouth. I put the tube inside the nose, catch it inside, and bring it towards the vocal cord. That's my personal, and it's a lot more safer, and it's a lot more secured. Okay, now we finished the main thing about the respiratory problem. Now we go to the gastrointestinal problem. Okay, babies have a lot of laxity in terms of the GI. I don't call it circuit and all the alimentary system. Then they have poor sucking. Now, how do you know that the baby can suck? When was the first time the baby sucked? Usually, though, they said around 34, it could be slightly lesser. That's why in the antenatal scan, korang akan nampak baby korang tengah hisap jari lah apa kan. They have that already. But before that, they don't have the ability. That's why they put the rice tube. but they do have reflux problem. Reflux problem can cause irritations. It can cause apnea because it's acid reflux, can just spill and then triggers a gag reflex so the baby, or irritation causing the baby to become apnea or cessation or breathing. They stop breathing for a while. Now, other problem that, when you start the baby on feeding, remember, yeah, when a mother deliver a premature baby, the first thing we're going to ask, okay, mak, tolong perah susu. The main one, you have to express the milk because we want to give that precious, valuable content towards your own baby. Yes, we do ask the mother to express the milk immediately. So it can give towards the baby via the nasogastric tube. It will instill inside the stomach. Okay, at least that you know that the baby is receiving all those. Okay, right? And then the other problem is the necrotizing enterocolitis. Now, this is the nightmare for neonatologists and pediatricians. Okay, so neonatologists and pediatricians then actually very scared about necrotizing enterocolitis. Technically, though, it's inflammation of the gut. It's overwhelmed with gut flora or all the
I'm not
bacteria.
really
If
familiar with your
and
you all
I need
punya
to mute,
protocol lah, tapi
and can some people mute the mic?
Chan say he going.
Okay. Anyway, so it's quite common in prematurity because the gut is actually not healthy, not yet. First thing, you have to tolerate feeds, and then after that you got a lot of infection, so it can gonna lead to inflammations. When you got inflammation, then you have to rest the bowel. You put on TPN, you put on fluids, total parental nutrition. Anyway, that's what I'm saying. Yeah. So it can cause apnea. The symptom and signs quite vague. It can be an apnea, distended abdomen. It can be vomit, bilious vomit, and so on. Okay. Kenapa dah ada comot kat depan ni? Tak tahu pula. Tak apa, it's okay. Okay, the abdominal X-ray then for a typical necrotizing enterocolitis, then you can see a lot of trapped air under the liver. You can see that all this particular parts of the apa namanya, the bowel is actually dilated. It's bigger than orang kata. Is a lot more bigger in the vertebral body, so it can consider to be dilatation. And sometimes, if it's a worst case scenario, then it can become perforated, so it's just like exploded or pneumoperitoneum. Okay, so what do we do with it then? So we just like keep the baby nil by mouth. Okay, we put nasogastric tube, and then we give antibiotics, and then sometimes we do need the help of the surgeon. The surgeon, they usually either they insert temporary drainage, usually made of rubber. It could be rubber from the glove. Actually, they just collapse it and then put it at the abdomen. I'll show it shortly. And then sometime though, in a worst case scenario where they got literally a necrotizing gut, then you need to resect all the dead bowel and re-anastomose. Sometimes that it cannot have a primary anastomosis. You have to divert it outside and call stoma. Okay, have a look then. What do I refer by stoma then? Okay, so you can see that there's a stoma formation there then. Okay, this is not a stoma, but rather this is a Penrose drainage. Technically though, you got free air inside the abdomen, you have to drain the air because the reason being though is distended. When you got distended, you got filled with air constantly, it will press diaphragm, and that will lead compromise of the breathing. So boleh imagine, perut buncit, dah tu dia tolak naik atas, so you can't really breathe. Orang kata say ke apa, I don't know what's the word in other Malay word of it then. So the problem with that though, they have short gut syndrome because too many dead gut. They got failure to thrive, they can't really feed properly, they got poor feed tolerance, and then they got strictures like any other abdominal surgery. Okay, now, this is the next thing. Now we talked about respiratory, we talked about the gut, the main one. Okay, now we talk about the bleeding inside the brain. It's called intraventricular hemorrhages. Okay, intraventricular hemorrhage is very common in premature baby that is less than 28 weeks or less than 32 weeks though. The reason being then again is all the blood vessels inside the brain and everywhere, as a matter of fact, that is so fragile. Any pressure, any stress, infection can lead to spontaneous bleeding. Okay, what do you mean by that then? Okay, so the sign symptom is quite rare. They don't really manifest. We only detected when we do ultrasound. As you can see then on the right side of your screen then, now there is hemorrhages there, okay? This is the coronal view. You can see there's the black of blood, okay? Now this black of blood though, it can reduce or it can increase. That's why the first week of life of premature baby, you need to do cranial ultrasound. because this bleed either can progress or it can regress. If it progresses, you have to see whether it's grade 1, 2, 3, or 4, or you can even develop hydrocephalus. What is hydrocephalus, you say? So technically, though, is an excess of cerebrospinal fluid, which you can see at the ventricles. You can see here, that's the lateral ventricles, and it can be dilated if there's an excess of cerebrospinal fluid. Okay, so you have to screen. Part of the screening of premature baby is to do cranial ultrasound. Okay, what is the complication of it then? Usually 1 and 2 will resolve. The 3 and 4 you have to monitor. You measure the head circumference. Okay, you monitor the ventricular index, or in other words, then how big the ventricle will become. Okay, if there is any development of periventricular leukomalacia, there's also a very poor prognosis for baby, indicating that it's a potential of any form of cerebral palsy. It could be hemiplegic, it could be quadriplegic. It all depends on the findings. All these baby have bleeding, and then usually we send for MRI in later. Can we do anything about it then? About all this bleeding, you have to make sure that the baby are just like in a top condition. In other words, then okay, don't let them like having low in oxygen, no form of infection. All babies are so fragile. Okay, they are just so fragile. There's a word in NICU, it called minimal handling. You don't simply lift up the baby. Have you seen a small baby, premature baby? It's this small. My 450 was that big. Can you imagine that? That is the actual length. Now, all I have here, look at this now. This is a big baby. Look at this, and it's a big baby. You can actually, baby are tough, just like, baby are tough. All right, so we just minimal handling with them. Okay, we talk about the brain, then the next up we talk about the patent ductus arteriosus. Patent ductus arteriosus. Ductus arteriosus alone, anatomically and biologically, help us because in utero, we don't get oxygen via our mouth or nose. Okay, we got our oxygen from the mother. So, in other words, then the lung is submerged inside the amniotic fluid. So where do you get the oxygen from? It's actually from our mother via the placenta. Okay, umbilical artery and umbilical vein. Now, when the blood actually from the placenta heading towards the baby and eventually going to the heart, then all these small particular holes helps a lot in crossing or bypassing the blood, the oxygenated blood from one side to another to supply the whole body with the oxygen. But this thing, the ductus arteriosus, if remain patent, okay, if remain patent, then it's troublesome. It can create a loud murmur. It can lead to heart failure. It can have apnea and everything. Then, so once the baby start to take their first breath, the immediate reaction from the baby's heart is the ductus arteriosus will shrink and close spontaneously. Okay, but if it's remained open, then that is problematic. Okay, so how do you manage the PDA then? Usually, though, it will resolve by itself. But sometimes, like I said, this is the one that lead to heart failure. The baby is not growing. The baby depends on the ventilator, respiratory support, and whatnot. Though usually we give medication. What is the simplest medication we can give to close the ductus arteriosus? Paracetamol. Yes, we give paracetamol to babies to close the ductus arteriosus. Now, people gonna ask, habis tu doktor, boleh ke ibu-ibu mengandung ni makan paracetamol? In a very good dose, it shouldn't be any harm. Okay, but yes, we do use paracetamol in patent ductus arteriosus to close it. If that is not available, we use ibuprofen. Okay, indomethacin is a bit obsolete, but paracetamol is the way now. On top of that, though, we have to make sure that we restrict the fluid. Kita tak nak just overload with fluid. If you got overload the baby fluid, then baby tends to have heart failure, and then you have to add on medication like furosemide and so on. Okay. So they are at risk for infection as well in the future. So other complication that we actually have, infection is number one. Because of before that I said to you before the baby even delivered, there is a potential complication from the mother, usually from UTI, urinary tract infection, or group B streptococcus. Now remember, 30% of healthy women population has group B streptococcus at the high vagina. So in other words, they just sit there, do nothing. Only 10% of them will go towards the baby, but from 10%, only 1% actually going to cause problem. Okay, but this, if it's cause problem, it can lead to septicemia, meningitis, and including pneumonia. Neurological complication, then, like I said, cerebral palsy, could be autism, and so on, or behavioral problem. Others we're actually going to mention afterwards then. Okay, I mentioned to you about the group B strep, E. coli, Listeria, and monocytogenes. Listeria, this is the one that, you know, mak cakap, jangan makan benda-benda yang dairy product, cheese and everything, unpasteurized cheese. Listeria will come by. Okay, so we just normally deal with this with giving intravenous penicillin and gentamicin. Now, gentamicin also can be damaging towards your kidney and to your ears. So be careful with that then. And of course, then this, sometimes you have to do it because in order to save the baby, you have to give antibiotics. And again, the baby is quite vague. They don't tell you they have infection. They don't manifest as fever. As a matter of fact, they manifest as hypothermia. But you as a physician, you have to tell whether the baby is not well or unwell. Usually they are not well, though they become less active, become bradycardia, apneic, and also desaturations. Okay, so you know that the baby has a lot of hardware going through their body. You got the endotracheal tube, you got umbilical artery catheter, you got sometimes you got chest drain, and a lot of things, a lot of phlebotomy work. Though this is all high risk of infection introduced from outside towards the inside. Okay, neurological problem then, such as movement disorder. Now, if you've got that problem in the brain, like any form, hypoxia, periventricular leukomalacia, any form damaging things towards the brain, then it will lead to cerebral palsy, which is a well-known and recognized complication of prematurity. That's why we need to follow up all these babies for their development, their motor development, their fine development, including coordination of feeding. Because if they have problem with feeding, then for instance, cerebral palsy, they are prone for aspiration pneumonia. It could be sudden infant death syndrome and so on. Okay, so depends in terms of what kind of complication that the baby has. They have learning disabilities and they have behavioral problems. They said that all the babies in prematurity actually have hyperactivity. I actually have to disagree. It depends on the genetic factors or all the other siblings are. So it all depends really, but there is a known risk factor as a prematurity to have behavioral problems. Okay, next up then. Part of our screening of all premature babies, we do retinopathy of prematurity screening. Technically, though, ophthalmologists will come over on a certain given day, usually in the morning. They dilate the baby's eyes and pupils, and they can see the retina. Because abundance of oxygen is not good for the small babies. The developing retinal artery or retinal, all the blood vessel behind that, if you give an extra oxygen, then it will actually damage the retinal vascularization, so leads to retinopathy of prematurity, hence leading to it become not controlled. It will lead to retinal detachment and blindness. So we do take the eye seriously as well. And some people say that sometimes 100% is not good. As a matter of fact, though, we maintain at 95 to 98%. In other words, we don't want the saturation go up to 100% constantly. That is only premature babies. Yeah. Mature baby, that if you blast the oxygen, then usually it's okay. They all relax, chill. Okay, so we do the follow-up then, and then other thing is certain things like all babies, they are at risk, they could have congenital deafness then, but in a premature baby, there is a higher incidence of sensory neural deafness because of the medication that we actually give, right? For instance, like gentamicin, vancomycin, that can damage the part of the hearing. So we need to monitor and make sure there's a hearing test being done. Okay. Now, once actually everyone is all ready and happy, the baby is gemuk, okay, usually 1.8 kilogram, 1.9 kilogram. Okay, how do we actually determine when the baby is ready to go home? Okay, usually all hospitals have their own criteria of weight, but they have to need to go through these three things. First, ni untuk orang-orang yang nak ada baby ke, you never know, you're going to have premature babies. At least three things. How do we let go a baby to go home? Dah lama, dah 2 months staying in the NICU, it's about time to go home. The parents are so scared because all of this while, actually, the baby has all the support in the world. You got nurses, you got the monitor to monitor the baby heart rate, the saturation, temperature, check makan, dibagi, lampin, ditukar. No, we don't actually spoil the mother like that, or the father like that. When the father roaming in, so they go inside the hospital and sleep with the baby, usually the mother, okay, not the father, of course. We will monitor the baby's feeding. First, the criteria, the baby has to feed properly without falling apart. Now you said then, what do you mean by falling apart? Falling apart meaning then that the baby will able to coordinate breathing and coordinating sucking. If they have that, then become apneic, desaturation, become blue, tiba-tiba minum biru kan, tak boleh balik. Stay back. Okay. Second, they have to breathe by themselves. Okay. They have to breathe by themselves. If they cannot breathe by themselves, obviously you cannot go home. Now they have no apnea, no whatever respiratory problem at all. Completely nothing at all. And thirdly, of course, the criteria of weight of the certain hospital. Certainly though, when we actually have the babies ready to go home, then we also, we don't encourage, we say compulsory. Usually I said, tolong ambil vaksin. Please give the vaccine. And people said then, okay, vaksin macam mana nak? Adakah nak ambil masa 2 bulan ke? Tak, macam ni ya. Vaccine in prematurity ya. If the baby was 24 weeker, so 6 months, 6 months ya. Umur dia 2 bulan. Bukan corrected tau. Maksudnya bukan count sampai due date. No. So technically though, umur dia 2 bulan, you have to vaccinate the child because that is the duration the baby has been exposed to the outside world. Yes, there are certain studies whereby that kata, oh, the immunity response is not as great. That's why we have serial of vaccination. We got the first dose, second dose, third dose, and booster, and sometimes first, second, and booster. It depends. Now, there are certain, now pneumococcal vaccine in particular now been integrated in the national immunization program. So that is wonderful. I am an advocate of pneumococcal vaccine. If your children doesn't have pneumococcal vaccine less than 5 years of age, and please give them. It's only one shot. It's protect them from meningitis, pneumonia, otitis media, and also septicemia. So please vaccinate your children with pneumococcal vaccine. Hanya baby yang lahir 2020 onwards here entitled to get the pneumococcal vaccine. So the rest of you then just unfortunately you have to purchase, ranging from 200 to 300 ringgit. Just one dose, okay? Other thing then, this is not a vaccine, it's called a palivizumab, okay? I'm going to mention that afterwards then. Other things that we actually advise the parents is, are you ready, okay? Are you able to feed your child? What's your plan to feed the child? And other things that I really hate, I'm going to say it out loud then. I know there are certain people inside this audience, participants are smokers. If you're a smoker, then the likelihood of your premature baby to develop bronchiolitis and to go to the hospital and to go to ICU is extremely high. Your baby's lung has already been damaged with the smoke particle. Tak kisahlah, you actually you smoke in the toilets, you smoke outside, the particle is still there because you lift up your child. When you lift up your child, they can inhale a secondary or tertiary smokers, then smoking is a no-no. I don't care. For those women out there that married to a man that is a smoker, then I know it's tough for you. And it's very difficult to make them to cease smoking. And I can assure you that. Okay, now palivizumab, you can see the palivizumab is not a vaccination. It's a monoclonal antibody. Semua baby and premature baby, that's usually less than 32 weeker, okay, 32 weeker, depends on financial status, should have the right to have palivizumab, is a monoclonal antibody, okay, to be given 5 times IM injection, 1 before home and the rest of them after going home 4 times in a 1-month interval. What does it do? It reduces the severity of bronchiolitis caused by respiratory syncytial virus. Harga satu vial ni nak dekat 3,000. So tolong jangan membazir. Honestly, it's so expensive. For those working in the government sector, yes, they can apply for JPA as a help. They can give you a grant or to help, okay, subsidy, but not all. For those that like B40 though, they have to actually ask from Zakat, and Zakat doesn't have much money. But regardless though, we try to offer as many babies as possible that is ex-premature baby with palivizumab. Tapi if you got palivizumab, if your father is smoker, forget it. Honestly, forget it. Just forget it. Okay? Sorry ya, dia emo sikit. Sebab benda ni selalu berlaku. Right? So what do you do in long-term follow-up then? Follow-up is very essential, mainly because of the brain. Sebab kita nak tahu dia punya perkembangan, dia punya motor function macam mana. Okay? Macam mana dia punya social interactions. Macam mana pemakanan dia. So all those things, how they actually eat. Are they growing? Are they gaining weight? Usually, small babies, premature baby, we usually add on a very specific or special formula, got high calories with low volume. Because this baby, though, they have a lot to catch up. They are small. In comparison with term baby, and usually they orang dah gemuk, memang dah gemuk dah. Tapi ada yang kecil juga. Tapi the babies are so small. Can you imagine 500-gram babies then? And then by the time they go home, 1.8 kilogram. By that time, it's only 35 weeks. And then people, bila dia masuk kelas, darjah 1, kenapa kau kecil? No, our son, our daughter, not going to able to say, aku premature lah dulu. They're not going to say that. Right? So we have to like work together with the parents and make sure that the feeding is actually okay. Give extra calories and make sure they are feeding well. Yes, we can actually introduce the feed a lot more earlier than any other babies. Like for instance, like all the term babies, then at 6 months, then we can certainly give at 5 months of age or 4 months of age, depending that the baby able to coordinate the feeding and able to swallow. Okay, because you are introducing solid. I usually recommend that semi-solid first, like very, very mushy and all blended, like literally macam bubur, okay? If not, the risk of choking is quite high. You can do trial and error then, janganlah kata error sampai tak boleh bernafas. It's not what I meant. Then you can see that the baby is ready. Kumat kamit, mulut gerak-gerak kan? So the baby is ready. Then usually if the mother said that to me, then go ahead and feed your child. It's not a problem, okay? So, so that is the, we have to monitor a lot of things, but mainly the perkembangan minda or the development of the brain. Okay, so behavioral problem, yes, there is association to autism, hyperactivity, like I mentioned before. There are certain studies that mention about the correlations between the autism and hyperactivity with extreme prematurity, less than 28 weeks, for instance. Yeah, learning difficulties. Then okay, when to start school? Like I said, then kalau dia birthday dia tahun 2020, masa dah umur dia 7 tahun masuklah. It's not a problem. Why you have to restrict? Oh, correct. Dia sebenarnya awal berapa bulan ke? No, you don't have to. Just put them, enroll them on the according to the year of they were born. Okay. Vaccination that I mentioned, chronological age, then do that. You don't have to macam tercicir vaccine. Yeah. I do recommend pneumococcal and influenza. As a matter of fact, for you guys out there, as all my fellow dentists out there, I would certainly recommend the vaccination of influenza. Thank you very much. Okay, reason being you are directly from all the respiratory droplets, and please get influenza, guys. Okay, influenza, pneumococcal, you can still get it yourself. I'm referring to you, yeah, not to the babies. Influenza and pneumococcal if you want. Okay, and of course the COVID-19 vaccine. I mentioned about the bronchiolitis. Then is the bronchiolitis is for the smokers at home, pneumonia, because you have to remember that the baby's lung is actually quite damaged. Okay, so as a premature baby, then we give her palivizumab, and we do recommend it's a high-tech prescription. Only doctors, especially for MOs, usually have to prescribe this. Okay. I mentioned about the feeding. You can start early if you want. You got high calories. They do have problem with food aversion though. They refuse to both breastfeed and bottle feed, and sometimes they actually quite picky eater. Now when they are picky eater, ini yang susah jadi pediatrician ni. Parents dia datang kata, anak saya doesn't want to eat, like very picky eater. And then they ask me that, what can I do, doctor? Like, okay, I can only recommend kejap. I'm actually going to shut the window. Okay, right. So all the solids and everything, and they are picky eaters. Susah sebenarnya. And you have to make sure that they have balanced carbohydrate, protein. You have to make sure they have good iron supplement, the folate and everything. That's why when the baby go home, we give multivitamins, including irons, because they have tendency of rickets of prematurity. They have anemia of prematurity. Semua letak prematurity at the back. Senang je in unit say. Retinopathy of prematurity, anemia of prematurity. Okay, so all those things have prematurity at the back. Right? Okay, so we monitor the growth, we ask about the dietary history very carefully then, and sometimes then if they still needed help, then we refer to the dietitian. Okay, neurodevelopment, like I said, we have to monitor the progress very well then, the IQ, the motor, the social, the fine motor coordination. One thing, guys, if you see a child less than 1 year of age, okay, is got hand preference, is usually is not good. For instance, then if you ask a baby, okay, so this is my airplane model, they pick up this thing, they pick up this thing, but they refuse to use the right hand. Why? Another word, then they have problem with the right. Usually they cannot open the fist, so they can't transfer the objects. If there is a problem, then please seek help as early as possible, because the child can have physiotherapy. Okay, so monitor their development very carefully. And when the development is monitored, is corrected age. Maksudnya, kalau anda kata baby tu lahir kurang daripada 6 bulan, masa 6 bulan, so dia ada diskaun 3 bulan. So, bila anak dia 3 bulan, sebenarnya anak dia bukan 3 bulan, 0 bulan. Faham ke? That's quite hard to grasp, tapi see how it goes, okay? Behavior then usually sama je sebenarnya, all the kids out there. Ada yang okay, ada yang nakal and everything, then they are multifactorial really though. But sometimes the main thing is really whatever happened inside the brain, then that is the most crucial, yeah. COVID-19 then, yes, there are trial out there. We talk about the COVID-19 prematurity in children. Kenapa budak-budak tak dapat vaksin? Kan? 18 tahun ke bawah tak boleh ambil vaksin, because there are trial going on there. We hoping then that Pfizer and Moderna actually were able to finish and complete their study with the cohort of the small babies, including less than 12 years of age, because we want to protect our children then from COVID-19. And but for some reason, yeah, children they are very good at COVID-19 though. They don't really, the COVID-19 doesn't really penetrate or stuck in their body that well. That's why you hardly hear the children actually have COVID-19. But certainly if a mother got COVID-19, then prior the delivery, there are slight increased chance of the child actually have COVID-19. Okay. Right, so the vaccine, hopefully we're going to have development then, and with luck then by the time or late this year, then we're going to have the vaccine for them. Okay, I'm actually going to be my last part then. In conclusion then, prematurity carries a lot of complications then. They need to be looked after very well. We need to follow up very well. We need to vaccinate the children then. But whatever that we do during their birth, during their delivery then, they are the most important thing. We make sure that they have a smooth and a very good journey ahead then in their life at the early stage, and even in the long term then. Okay, I'm gonna complete this with a demonstration of a video, okay, how we as neonatologists will, I'm gonna stop sharing, okay, here am I again. Okay, everyone can see, yeah? Okay, here we go. Do you see the babies? Okay, I hope it's focused then. Okay, here we go. Okay, now this, I'm just going to show to you, this is our laryngoscope. Okay, it's quite big, it's quite bulky. Okay, it's very bulky indeed then. Okay, they got a different handle. We connect it like that. This is a straight blade. See that? It's quite sharp. Okay, how are we going to introduce it then? Okay, this is the mannequin that I actually borrowed from Clinical Simulation Center. Okay, now, nampak ke korang? Macam tak je. Okay, there you go. Okay, I'm going to introduce this. Now that's the mouth there. Introduce it, and we go up here like this. We go to vocal cord. You see my position. You see that? Okay, I'm going to show it to you closer. Okay, that's the position there. You see the position of the laryngoscope, the blade. The blade is located at the lower lip, the upper lip. It's actually has a fulcrum effect. So you lift it up until you see the vocal cord, which is, sorry, I got too excited about it. So that is the vocal cord. I don't know whether you can see or not. Okay, we can see the vocal cord. Sorry lah, tak nampak. Okay, so literally though, it might potentially damaging because of this movement or this maneuver. And then when you actually remove that, you introduce the endotracheal tube as such. Okay, introduce it like that, and voila. So that is the position of the endotracheal tube. Okay, and I hope that's somewhat benefit in terms of my demonstration today. Okay, so there you go. That is my thing. Before I end, then hold on a second. I have one more thing to give to you. So with that talk, that is my last slide. I also gonna just like give you this particular slide, which is for your next speaker in when is it? April 21st. Okay, I'm gonna pass back to Faisal then for this then. Thank you very much. I'm gonna stop sharing.
All right. Thank you so much, Doctor, for a very fruitful and very entertaining, very informative lecture, I would say. Let me see if there's a question. There's one question actually. She asked, "Good afternoon, Doctor. What is NEC?"
What is NEC? NEC is necrotizing enterocolitis. Necrotizing enterocolitis is and necrotizing enterocolitis is inflammation of the gut due to prematurity and overwhelming of the gut bacteria. So that gut bacteria usually it manifested as dilated lower bowel. Maksudnya the abdomen become distended and become perforated, and usually baby tak boleh makan dah lepas tu. When they cannot eat though, they cannot tolerate eat, or they just keep on vomit because the perut dah buncit. It's quite tender, literally it's actually tender, okay? It's distended, okay? After that, they just vomit, bilious vomit, okay? They're not tolerating feed. They become hypoxia, become hypothermia, and so on. And usually that the management, kita kena stop the feeding. We stop the feeding then, after we stop the feeding, and we just monitor the progress of the baby. Okay, that is necrotizing enterocolitis. Yep.
Thank you, Doctor. I think our president, Dr. Joanna, just raised her hand.
Okay,
yes, Dr. Joanna,
go ahead.
First of all, thank you, Dr. Masri, for agreeing to speak in our webinar. It was a very, very enlightening lecture, complete with demo. So I really appreciate that. Now, my question is, with all these problems that they have regarding their respiratory issues, are they at any higher risk for general anesthesia when they are older? For example, we get a lot of children that we do general anesthesia for comprehensive dental treatment, you know, so are they at any higher risk?
Okay. Now, usually though, if a child requires a surgical intervention or require anesthesia, then we refer to the anesthetist first, of course. But the more complication that you see, like you got patent ductus arteriosus, you got respiratory distress syndrome, chronic lung disease, apnea, memang anesthetist akan gelabah. Definitely. They're going to be so scared of it though. Yeah, but if as a neonatologist, then I would say then this child has been on oxygen for quite some time, but since going home and doing my follow-up, then the child has been good. There's no reported apnea and has been thriving. And usually with that kind of word, they usually feel a lot more reassured. Despite saying that, I agree though, there are potential of apnea or even complication of surgery during the anesthetic agent that actually gone through it. They are scared, honestly. Usually if there is a surgical intervention, then they always pediatrician or neonatologist be on standby. You can actually go to IJN, to HKL, they do this a lot. Okay, the anesthetists usually just they are proven that. What I'm trying to say is, yes, there is a risk depending on what kind of comorbidity or background medical history there is, then, but also yes, the chance of successful surgery with anesthesia are usually quite high. You have to do it. You have to do it. You know.
Thank you, Dr. Masri. Let's say they are already 10 years old or they are 7 years old.
Usually no, not sure. No, Joanna, definitely no.
Okay.
That definitely like 10 years old usually tak kot. Unless they are the ongoing problems. If you got a problem with cardiac problem, yes, that they are as similar as risk of any other children. Put it that way then.
Thank you very much. That's a very clear answer.
Okay.
Thank you, Dr. Masri and Dr. Joanna. Let me read another question from Dr. Habibah. Is there any association between hypoxia in babies with autism or ADHD? And what if they actually pass all the tests for behavioral abnormality? However, the mother noticed the behavior abnormality of the child. What should the mother do prior to the visit to a pediatrician?
Okay. That is from Habibah, isn't it? Yeah. Okay. First of all, yeah, there is, like I mentioned before, there is increased risk of a behavioral problem, namely autism and hyperactivity. Yes, agree. Like any other child that has been detected early with autism and hyperactivity, then you have to first seek medical attention, namely pediatrician or developmental specialist, and then they will actually they will do a multidisciplinary management, whereby they're going to have the physiotherapy, the occupational therapy, the pediatrician. We need the psychologist to assess that. In answering your question, yes, there is a increased risk of autism and hyperactivity in premature baby. There is studies actually proven that there's a direct correlation.
Thank you, Doctor. There's another question from Nisha. Hi, Doctor. For premature baby, at what age would you recommend to start solid food?
Okay, like I said then earlier, the solid food then, it depends. Usually we give discount, massive discount. As I said then, for all any other babies that is term baby, like 37 week or above, we start off at 6 months of age. But in premature baby though, you can start when they actually are 4 months or even 5 months, providing that your child or the baby able to coordinate and able to swallow. If you're scared, your premature baby is scared, like not premature baby scared, you yourself scared, then you can actually bring to the speech therapist to initiate the feed, because the speech therapist can assess whether that the child or the baby can able to swallow. But usually though, at 4 or 5 months chronological age, you can start feed. Before that, you need a high calorie formula, a special X premature formula to gain weight. Okay.
All right. Thank you, Doctor. We have, I think, if I'm not mistaken, not less than 10 question. I'll just read whatever. Hi, Doctor, from B Tao Liao. Can we use spoon to feed premature baby with cleft lip and palate, or clapham bottle? Okay, right. With cleft palate, is it? Did you say? Yes, baby with cleft lip and palate. Oh, you need the completely outside the thing is more towards max spec. Okay, right. What we do with a child with a cleft palate then? Can we feed with spoon? Now, believe it or not though, some babies with cleft lip or palate, especially palate, then they still have ability to drink either from breastfeed directly, latch on, or even from a cup or a bottle. Depends on the severity or the stage of the cleft palate and lip. If by any chance that the child's severity or the grade is high, you got the bilateral cleft lip and palate, then of course, obviously, or it depends on the severity though. Usually if you got cleft lip and palate, we admit to NICU. After we admit into NICU, then we assess the feed. Okay, you can give cup, small cup too. They actually, if they have ability to not really lift up and sip though, we lift it up and sip, and actually they will start like macam try to drink from it. Then if they have the coordination able to swallow, but rather going up to the nasopharynx and towards the lung, then, and in that case then yes, they can feed normally. There are a lot of babies out there that actually doesn't have to have this all these Haberman's teeth or special teeth, or even the artificial palate and everything. Then no, they don't. It all depends on the severity. All right. Thank you, Doctor. It's another question from Dr. Ilham. Hi, Dr. Masri. My question: would the babies with respiratory problem during the first few months of their life would have higher chances of having arch development problem, like delayed development of the maxilla and mandible? Wow, this is this Ilham from UITM, is it? I assume so, because it's just mentioned Ilham. She's really get me outside. So they said that development problem, like delay development of maxilla and mandible. To be honest, now I have to be really track this question properly though. If the child has good nutrition, usually it's not a problem. If the child develops any other form of deficiency, either micronutrients or macronutrients, especially vitamin D deficiency or rickets or prematurity, I would say yes, there are certain extent they will have a problem or development, but in a whole, not particularly at the maxilla or the mandible. I might be wrong in answering that though, but in a general, development of bone relies on vitamin D, the calcium and phosphate. So they have to have a good nutrition. If they have any form of rickets or anything, then yes, it will impede and cause problem towards the bone development, regardless of whether maxilla or mandible. All right, thank you, Doctor. I think I'll just take one last question, because it's actually almost 2 o'clock. This one, the last question from Atika. Doctor, is the usual term jantung berlubang is actually referred to PDA?
Okay. Now, this is a common Malay term that use jantung berlubang. Jantung berlubang is actually banyak. Dia ada ductus arteriosus boleh, ventricular septal defect boleh, atrial septal defect pun boleh. Kita kena tanya. Itulah sebagai seorang ibu, I would recommend that bila doktor tu cakap kan, jangan refer kepada jantung berlubang je. Minta dia the whole term. So it's not directly refer to patent ductus arteriosus. Tak sama sekali. It could be other form. Dia ada banyak yang lubang yang kat atas, yang kat bawah. Tapi commonly, it is ductus arteriosus. Tapi it's a wrong terminology. Bagi nasihat saya ialah, tanya doktor the exact term. Okay?
All right. Thank you so much, Doctor. I think it has been. There's one last question.
Okay.
Is it possible, Doctor?
Yeah, sure. I have no problem. I have nothing to do.
Okay. From Prasanna, I think this is the last question, I promise.
Okay.
Hi, Doctor. I remember you saying earlier when the baby is born prematurely at 6 months old, when the baby is 3 months old, we should treat the baby as age 0. Because she mentioned that she find it a little contradicting about the feeding.
Okay, I get what you mean, yeah. Okay, macam ni tau. Put it this way then. If the baby is 6 months of age, then technically there are 3 months to go until they are full term, which is 9 months, which is 0 point. Macam ni lah, macam kita main 0 point, yeah. Okay. In term, talk. Right, okay. In terms of the vaccine kita bagi according to chronological age. Maksudnya at 2 months of age, 4 and 6. So maksudnya even though they actually were born 6 months, at 8 months of age, dah bagi the first vaccine. Okay. Now, for feeding has to be corrected gestational age. Can you imagine that, let's say that the baby is 6 months, chronologically, around 5 months of age, the baby is only 2 months of age. At 2 months of age, then the baby has poor swallowing in terms of solid food. Then they're going to impede them and going to have problem with swallowing, and they're going to end up having choking episode or aspiration pneumonia. What am I referring to is that if you want to introduce or weaning, okay, feeds, is around 4 to 5 corrected gestational age, CGA. Yeah. So that is the sense of it in it then. So when you start feeds, is at the corrected gestational age. Faham ke? So in other words, then if you got like you've got a 6 months of age baby that is premature was 6 months, technically the baby is 6 months chronologically, but corrected gestational age, the baby is only 3 months. And at 3 months, the baby is not yet ready to feed. But sometimes they are baby as early 3 months, tak boleh, tapi it's very early for me. Usually 4 months itu dah early sangat tu. Okay, I hope that somewhat give a pencerahan, ya, Prasan.
All right, thank you, Doctor. I think we have reached to the end of our webinar for today, and I'm quite surprised that we still have more than 100 plus participants here. I don't know whether these are my fans or your fans. I think this is your fans lah. My fans dah lama left dah. Anyway, I hope everyone can join me to give a virtual round of applause to Dr. Masri for a very entertaining and very insightful lecture. And we are very honored to have you, Doctor. And we hope to have you again next time, Doctor. Okay. And with that, on behalf of MPD, thank you, and I hope to see you in April. Thank you, and Assalamualaikum.
Okay. All right. Thank you.